Respected Chairperson, learned audience, it's my great pleasure and honor to present something on PTMC in front of the pioneer of PTMC of Bangladesh, Professor Sufiya Rahman. Salute, madam. Assalamu alaikum. I am here with the contemporary complication and bailout of PTMC. I will start with few cases. Before starting, the complications of PTMC are patient-related due to their clinical and anatomical conditions and operator-related. This is the case 1. A 32 years female is severe mitral stenosis, and we are doing the PTMC puncture, and after puncture, what we see, the puncture needle pierces the aorta, and we are just in front of the coronary arteries. We are very lucky that we not perforate the coronary arteries and the nightmares in cath lab. But fortunately, this patient is very well tolerated. There is no pericardial effusion. We wait for 15 minutes. Then the puncture is done and the PTMC is completed. Probably the aorta is so elastic that the puncture with a Mullin sheath, there is no clinically significant event. My case 2, this is a case of severe mitral stenosis. Valve area is 0.5 and there is no significant MR. And we are doing the PTMC. The puncture is done already. And the LA-graphy is done. But we face very difficulties to enter into the LV. We tried our every methods but failed. But lastly, when we succeeded to enter the LV, if you look at the left panel, the force of entry into the LV from LA, we could not control, and it hit the lateral wall of LV. And on the we pull it, but there is some entrapment. The distal balloon will be inflated fast, but when we inflated, the proximal one was inflated. So there is an entrapment probably within the papillary muscle. Then we again pull it back and the PTMC completed. But after completed the PTMC, the cardiac silhouette is enlarging. The border movement of the heart movement is not well visualized, and the patient went into a cardiac arrest. We are doing the CPR and the puncture pericardial fluid aspiration. A hemopericardium is developed. Pigtail was introduced into the pericardium, and 300 ml of blood is auto-transfused, and the patient is improving. And if you look at the patient is gradually improving. And this is the handheld echo done in cath lab. The pericardial effusion is also decreasing, and the heart contraction is good. And this is after 300 ml of pericardial fluid aspiration, the patient is doing well. We wait for 30 minutes in the cath lab. There is no new accumulation of pericardial fluid. And then we shift the patient to the CCU, and this is the pre-discharge echocardiography. The valve area increased to 1.3. And there is an interesting finding in echo. We have no experience with this type of, when we do the global longitudinal strain, the strain is all over there is red or near red, but in the inferolateral wall it is blue. So that might be the site of injury of the LV. The complications of PTMC, in-hospital mortality, hemopericardium, embolic events, and severe mitral regurgitation. And this is the frequency of different studies. The fatality rate of PTMC varies from 0 to 3%. The main causes of death are massive pericardium, hemopericardium, or poor condition of the patient. The hemopericardium, when occurs, related to transeptal puncture, and in our cases, we suspect that the left ventricular perforation by guide wire or the balloons occur in less experienced operator, unfavorable patient characteristics such as severe left atrial enlargement and severe thoracic deformity. The incidence varies from 0.5 to 12%. The hemopericardium usually has immediate clinical consequence resulting in tamponade. When to suspect? If hypotension develop, the echocardiography confirms, and increased cardiac shadow is the telltale sign. How to treat? Immediate pericardiocentesis under echo guidance, reversal of anticoagulation. Most of the time, pericardiocentesis is sufficient. PTMC can be reattempted, and surgery if fails. Preventive measures: adopt a good technique of septal puncture, either Inouye or hung method. Be gentle during the puncture needle, wire, and balloon manipulation. This is the Inouye and hung methods. We usually prefer the hung method, and this is the hung method. The lower end of the pigtail is the superior end of the tricuspid valve, and the lateral border of the LA, we make a straight line. Midpoint of that straight line, we make a vertical line, and the puncture site is the transaction point of these two lines, 1.5 vertebra below. So this is the D is the vertebral height. So transaction point below 1D is the within this this limit will will puncture. So the position of the puncture needle is very important. 3 to 6 o'clock position in levocardic patient, and 7 to 9 o'clock position is the dextrocardia patient. I have the experience of a patient with dextrocardia with PTMC, probably the first reported case in Bangladesh. So this is the position of the needle. 40, if the LA size is 40, is 4 to 5 o'clock. 40 to 50, 5 to 6 o'clock is if it is larger, 6 o'clock. And this is the lateral view before puncture, the septogram. We confirm with lateral view, and this is the puncture, safe puncture. And the embolic event, the sources is LA appendage thrombus, but thrombus that develop during procedure if we not anticoagulate properly, air leaking, calcium embolism, and embolism encountered in 0.5 to 5%. The management: coronary embolism, thrombus aspiration and PCI, air embolism, atropine if bradycardia, fluid expansion if hypotension. And the cerebral embolism, stroke specialist by thrombolysis or aspiration. Prevention of thromboembolism, it is very important. Detection of left atrial thrombus before PTMC, take the help of transesophageal echocardiography, heparinization during the PTMC, and careful de-airing of the balloon. And this is the 3 views of transesophageal echo, how to we confirm that the LA appendage contains no thrombus. This is the 30 to 60 degree view, this is 90 degree view, and this is very conventional but very new views of 135, where the LA appendage shows the highest volume, and we can see the pectinate muscle also. So this is how we can adopt the 135 view for LA appendage in transesophageal. This is the last one is the LA appendage transesophageal. This is the last one, this one. So PTMC severe mitral regurgitation occurs in non-commissural leaflet tearing, excessive commissural splitting, rupture of a papillary muscle. The frequency of severe mitral regurgitation ranges from 2 to 19%. This is the commissural tear, anterior commissurous tear in the upper panel right. Evaluate the severity, hemodynamic tolerance, echocardiography, Doppler, systolic pulmonary pressure, and severe size of the V wave. Understanding the mechanism, echocardiography, and treat. If there is a hypotension, IABP and emergency surgery. No hypertension, only the increase of pulmonary hypertension, schedule for early surgery within days. If there is no pulmonary hypertension, schedule for secondary surgery if not contraindicated. Prevention: adopt balloon size according to the patient's characteristics, step-by-step balloon size by echocardiography, stop procedure if a new MR +1 appear or signs of paravalvular tear. This is the measuring of balloon, and this is all know how to measure the size of the balloon for a patient. And this is how the step-by-step. First step, there is a partial inflation of balloon, and then we check the echocardiography, then the full inflation of balloon, a bigger size. So this is the step-by-step in balloon inflation. So Ptmc hypotension during the procedure, we look for the ECG. If there is bradycardia or ST elevation, we should suspect the air embolism. Look at the LA pressure, large V wave, there is a severe mitral regurgitation, we should give the specific treatment, and look at the echocardiography, tamponade and drainage. So criteria for stoppage of Ptmc is the valve area more than 1 centimeter per meter square plus complete commissural opening of at least 1 commissure, appearance of increase of more than 1 grade MR. And this is the criteria for successful Ptmc: echocardiographic valve area more than 1 centimeter per meter square, echocardiographic showing splitting of 1 or more commissure, decrease of LA pressure by 50%, decrease in the length of the disappearance of diastolic murmur of mitral stenosis, decrease in the gradient across the Doppler, and pressure shoot-up sign. So these are the long-term result, 9 to 12 years follow-up, 30 to 9 up to 90% event-free survival. So thank you for your patience hearing.